retinopathy is one of the complications that unfortunately start to increase with the rate increasing in diabetes as a general, especially in the Middle East and more in GCC. Talking about the retinal anatomy, all of us, we know that simple things about the retina. Retina part of the eye, it's a neural inner coat of the eye, consists of 10 layers, and these layers, they are very important in transmitting the light from a light wave light to electrical current through the photoreceptor cells. This is the clinical pictures, and that's the anatomical. And we can imagine any changes in the form of a microvascular level. Here we are talking about end arterial system, and any pathological changes involving this end arterial system that I'll show it to you, it will create a lot of deformities. Diabetes involving the eye from the corneal epithelial layer till the optic nerve. So we are talking about the optical system and the neural system. Here we will concentrate about the neural system. So diabetes will interfere with the passing of the light and transmitting of the light to electrical current. So the changes in the retina, it will interfere with the whole picture forming, quality of this picture, shape of this picture, and distortion, and then end up with a blindness. And unfortunately, we have a high rate of blindness, especially in GCC, because we have a high rate of diabetes mellitus. All of us, we know the diabetes mellitus, but the important things for us as an ophthalmologist, the insulin-dependent diabetes mellitus and the non-insulin dependent. Insulin dependence usually associate with one of the form we call the proliferative diabetic retinopathy, which can accelerate the process and the deterioration to blindness. Type 2 mostly associate with maculopathy. And unfortunately again, because of the uncontrolled and the uncontrolled A1C, we are seeing proliferation in type 2, especially in GCC. Now if we define what's the definition of retinopathy, it's a progressive dysfunction of the neurovascular tissue that lead to dysfunction of a neural tissue. So it is a microangiopathy because of the diabetes that lead to dysfunction, occlusion of the vessels, leaking of these vessels, and because of these, we will have hypoxia of the retinal tissue, and we have exudate. That exudate starting from a fluid to hard exudate lipoprotein, and then opaque or opacity of the transparent retina. This opacity will interfere with the vision, and the hypoxia will interfere with nourishment of this transparent neural delicate tissue and the organization that I showed to you. Any disturbance in this organization in a form of fraction of millimeter, the vision will be disturbed. And which area that it will be disturbed? The macular area that will be disturbed. The macula is the most central part of this retina that have high affinity to the diabetic retinopathy because of the organism, because of the vascular coat or vascular arrangement around the macula. I need just to talk a few things about the epidemiology. The total number of people with diabetes is projected to rise from more than 250 million in 2010 to more than 430 million expected in 2030. UAE in 2010, 2008, it was about second on the wall, but now it's 11. That's not because the rate of the diabetes mellitus is decreased, no, because we have a lot of enhancement in the statistical study of the other world. So their number raised, and we found that in Brazil, it's now the second, and South America start to raise more and more. So they took the position of UAE. But still, we have a high rate of diabetic mellitus in UAE, and it's increasing. Now, diabetic retinopathy is responsible for 1.8 million of 37 million cases of blindness throughout the world. Diabetic retinopathy is leading cause of blindness in people working in industrial area. Again, in UAE, we have 1 out of 5 now. Each 5, we have 1 of them diabetic, at least prone to be diabetic, or have a history of, family history of diabetes, whatever. Now, after 20 years of diabetes, nearly 99% of patients with type 1 diabetes and 60% with type 2 have some degree of diabetic retinopathy. Now, we will talk about the duration. It's a very important risk factor. 33% of patients with diabetes have sign of diabetic retinopathy, which means that if we have 130 or more than 30% of them, they have diabetic retinopathy. And we need to know that it's one of the leading causes for blindness here in this country, at least. People with diabetes are 25 times more likely to be blind than the other population. And that's also important. If we talk about the symptoms of the diabetes, and that's important things, I put it here just because we are talking about diabetic retinopathy in front of physicians or endocrinologists. And that the important things that I'm facing it in my clinic, in my center. And I'm dealing with most of the patients in diabetic. Here, when diabetic patient attending a physician clinic and saying that, well, I don't have any issue with my vision, or the physician sent him to an optometrist that he has it in his center or in any center, or in his center he's testing the vision and it's 6/6. It's not mean that this patient is safe or the retina is normal. It means that the macular area is still not involved in this patient, or at least the central fovea is not involved in this patient, because sometimes patients they have refractive error that they cannot prescribe the vision in a good way. So, or their vision is already blurred, so they cannot notice any metamorphosis or changing in the shapes of the frames or anything. So here they will not notice these changes until late. Or the patient's coming to me saying that, doctor, 3 days back I was giving lecture. I'm a teacher. And I was giving lecture. My vision is 6/6, now I'm not seeing. Here we have an acute bleeding. So he has the proliferative stage progress to be in a way that it starts to bleed, and then he notices. And from that point, I can discover that he's diabetic. So he didn't know that he's a diabetic. Because not here, we have a lack in education. And that education, personal education to the patients, to the general population, and few education that we need to put it for the physician to educate the patient related to the vision. The most vulnerable and most popular symptoms that the patient's coming with blurred vision. Floaters. And the floaters here, it's a risky in diabetic. And I'm asking them directly, you are diabetic? Yes. Okay, here it means that we have a bleeding, because this floater is coming from blood, drops of blood leaking with any increase in his blood pressure. And then I'm asking it another question. You are hypertensive? Yes. For how long? 10 years. You didn't attend any ophthalmic clinic? No. You didn't refer to any ophthalmic clinic? No. Okay. No one checked your fundus? No. And all of us, we have direct ophthalmic scope. It's a very simple tool and very easy to use. For a physician, he can take only a look to the retina. Any changes than the normal, this is an indication to refer this patient to the ophthalmologist. Any changes, whatever, we are not asking about the type of these changes for a physician. Any changes, blot and dot, background, anything, this is an indication for this patient, especially if this patient crossed the 5 years, or still in the 5 years, but he has an hypertension. So we have 2 factors. This patient should refer to the ophthalmologist. Or we might have a non-mydriatic fundus camera. Now we have it in diabetic centers. These non-mydriatic fundus camera is very, very important tool that we can take a direct, with a simple technician, direct picture to the fundus and send it to a GP ophthalmologist. We need only GP ophthalmologists in these centers, in order that he can filter these cases and send it to a specialist when this patient is in need to be referred, when the stage of the disease starts to be threatening the macular area or threatening the retina. And we will see how it's formed. Definitely we have fluctuation of the vision, distorted vision, dark areas in the vision, poor night vision, impaired color vision, partial or total loss of vision. That's what we call the advanced diabetic eye disease. I'm very sad to see a lot of patients, they are ending in blindness. Definitely he lost one eye, and he don't care, that's all, he has another eye. So, he progressed, and the condition progressed in the other eye. And because his neighbors, they told him that don't go to the ophthalmologist, he will do laser for you. And that's, I lost one eye from the laser, and the other guy lost his eye from intraocular injection, and so on. And so he will not go. From this point of view, we have a lot of lack in information, a lot of lack in education, popular education. We need, through the media, through the press, whatever, that it should be concentrated about the signs and symptoms, the complication, and we might end in a blindness. And then they are asking me, so if we will control our blood sugar, this condition will improve? Definitely not. It can improve if the condition is related to the edema, bleeding in the vitreous. But the level of the deterioration that resulted from the ischemic changes, it's irreversible. How can we turn back? When we have a lot of area of capillary avascular zone, we don't need to reach this state, especially when you are controlling the diabetes through their limited